All right. Hello, everyone. Welcome. Thank you for your patience. We had a little bit of technical challenge, getting everyone in from the work group and getting things settled for everyone. But I think we're ready to start now. So I appreciate everyone joining us. We're excited to have all of you here. I am going to ask Liz to advance the slide so we can talk just about how we're going to do Zoom etiquette for our members of the public today. We've already run through it for our work group members. First thing, and it's not on the screen, is I'm going to add, we seem to be having a challenge where some of you may be accidentally sharing your screen. You shouldn't actually be able to do that, but it seems to be happening anyway. So I'm going to ask everyone to do your very best to avoid clicking that share screen button, whether you're a member of the public or a work group member or staff member. Couple more bits of Zoom etiquette for our members of the public today. You should not be able to unmute your button today, and you should not have your video camera on. If for any reason you are able to control those, I'm going to ask you to keep your mic on mute and keep your video camera off, and you can find those functions in the lower left-hand corner of your screen. View of screen, the best way, my recommendation is that you click it on gallery view. That way you'll see a lot of faces at once rather than just the person speaking, but that's up to you. We have disabled the chat function today because there are so many people participating, and it would just be very difficult to monitor both our on-screen engagement and the chat. And finally, public comment. We have 7 people who have registered to make public comment. That's going to be at the end of the meeting today at 3:40 p.m. I promise you will be unmuted and your video camera will be on for your public comment. And we'll talk through the process when we get to that stage. I'm going to pause now and ask the real Michelle Needham to just say a few words of welcome. Michelle Needham is standing in for our fearless chair, Sue Birch, who is on annual leave right now. Michelle?
It won't let me unmute. Can you hear me?
Oh, we can hear you now.
Okay, good. Excellent. Sorry. This has been an adventure, hasn't it? Thank you, Jamie, and the whole HMA team for getting us started electronically. I know it's been an adventure and another demonstration really of our flexibility and perseverance during COVID. So I appreciate your hard work getting us ready for today and transitioning to our first virtual meeting of the Universal Healthcare Work Group. So welcome everyone to the meeting today. My name is Michelle Needham, yes, the real Michelle Needham, and I am the Chief Policy Officer for the Healthcare Authority here as Sue's designee for the day. She won't be able to join us. Before I begin and turn the agenda over to Jamie and team, I'd like to take a moment just to acknowledge the challenges each of our work group members may be experiencing during this historic time. And we want to express our appreciation for your patience as we've reconfigured our meetings and continue to work virtually, and to acknowledge your ongoing commitment to this work, to engaging meaningful discussions together, although virtually. So I hope you had the opportunity to watch the advanced video that we prepared with the COVID-19 briefing, just to provide a little bit of flavor for how things have changed since we last met in person. Sue did reference in that video the significant and historic events happening across the country and across the state that have devastated our economy and overwhelmed our healthcare system, and highlighted deep social and racial injustices that we will continue to work on together. So we will hope to find meaningful and strategic ways to influence our health outcomes and make healthcare accessible and affordable to all who live in Washington. And that really is our agenda together as we work throughout the summer and fall to complete our assignment. So with that opening comment, I'll turn back to Jamie to get us started on thoughtful and meaningful discussions that we've planned for the day. It is a very full day. We've tried to condense it as much as possible, but there's a lot of work ahead of us to do together. So we look forward to joining hands and plowing through this work.
Thank you, Michelle. Liz, would you advance the slide, please? Okay, I'm just going to take us briefly through the meeting agenda and just a reminder of what our goals and objectives are today. Our principal goal today is to prepare for the actuarial analyses of the 3 models of healthcare. So our specific objectives are we're going to discuss and get your feedback on the 3 draft models that you have seen. Actually, Liz, can you go back to the previous slide, please? Thanks. So that the actuaries are going to model for the work group. We're going to also review what's next in our process, including plans for the August work group meeting. Of course, confirm action items and next steps, and finally hear public comment on universal health care and today's proceedings. Liz, you can advance the slide, please. So just a quick overview of the agenda. Shortly, we're a little behind schedule now because of our slow startup, but shortly we're just going to hear a very brief presentation from our HMA Optimist team, just recentering us on what we're going to be discussing today. And as a reminder, our expectation was that all work group members had reviewed the pre-recorded presentations prior to this meeting and submitted questions. So we're not going to be spending any time on Q&A, but actually moving straight from there into our breakout groups, where we're going to have you discussing and refining and proposing refinements to the 3 draft models that you've learned about. There will be a 5-minute stretch break around 2:35 p.m. It's going to be the between the first 2 breakout discussions and the 3rd one. Liz, can you advance the slide, please?
Sure.
At 3:10, we're gonna all come back together in the main room and do a report out, and this will be an opportunity to hear about the discussions in all of the breakout meetings. And then at 3:35, we'll run through our action items and next steps, and at 3:40, move into our public comment period, and adjourn today at 4 o'clock. Liz, can you advance the slide one more time, please?
Sure. Jamie, can you remind folks if they're not work group members to please turn their camera off?
Okay, yes, I'll just do a quick reminder. Members of the public, I'm going to ask you if you could please leave your microphones on mute and your cameras off. Normally, we would love to see your faces, but it's unfortunately really challenging to be able to facilitate with our work group members when 130 people have their cameras on. So we will ask you to leave those off. When we get to our public comment, those of you who have signed up to comment, we'll make sure your cameras and microphones are on for your comment period. I'm just going to very briefly run through our decision process to remind you of where we've been and where we're going, what we're doing today. As you know, in September of last year, we came together the first time as a work group. The main purpose of that meeting was to set the stage for our work together and also to do some level setting and secure the same baseline level of understanding of universal health care and our starting point. Then in December, we met, and our work then was on articulating problem statements to address, to clarify the problems with our current system and do some root cause analysis. In February, which is the last time we all got together in person, and it feels like a million years ago now, we got together and we developed some draft assessment criteria by which we will consider universal healthcare models. Of course, April was canceled due to the coronavirus pandemic. Liz, can you advance the slide, please? So here we are today, June 2020, and as I just mentioned, we're going to be focusing on refining 3 draft models of universal healthcare so that the actuaries can start their analysis. In August, end of August, I believe it's August 26th, we're all coming back together, and the focus of that meeting is going to be on applying that assessment criteria we developed in February, specifically the qualitative criteria, to starting to assess our models of universal healthcare. We're also going to get a status update from Optimus on the actuarial analyses, and they may have a few questions, follow-up questions for us at that time. In September, we'll have the outcomes from the actuarial analysis, and we'll use that to do a quantitative review of each of our models of healthcare. And then our aim is that October, when we meet, we'll be focusing on developing the recommendations that will go in the final legislative report based on the outcomes of these assessments, and also identify issues that have not yet been addressed but still need attention. And if possible, some recommendations for how to address them. So that's the plan. There's still the possibility of a meeting, another meeting that we'll add, but we will be getting back to you soon about whether that's going to happen and what the topic's going to be. Liz, can you advance the slide, please? All right, we're about to move into our very brief presentation from Nora and Shane, and I may even ask them to do a speed round just because we're a little behind schedule. But before we do, I do want to to share some updates with you about some members. Primarily, Aaron Spark with the Indian Health Board is on leave, and he is being replaced temporarily by Vicki Lowe, who's the Executive Director of the American Indian Health Commission for Washington State. She'll be filling in while he's out. And I'm just ask Vicki to take 2 minutes to briefly introduce herself to the rest of our work group. I know some of you know her very well, but Vicki, could you just say a few words?
I think I was able to unmute too, right?
You did, yeah.
Yay.
Wonderful, yay.
It worked.
Good afternoon. Yeah, thank you for having me. I really had wanted to be on this work group in the first place, but realized I didn't have enough time, so things sometimes work out. I am the Executive Director of the American Indian Health Commission. Prior to that, I worked for the Jamestown Slalom Tribe in our health program. And our health program started out as we bought insurance for our tribal members because we didn't have a clinic, which we do now. So I've worked with basic health. We used to buy basic health, non-subsidized coverage for our employees. We work with Medicare. I worked a lot with Medicaid. And then eventually I started working also because at a tribe you don't get to have just one job. I got to work in HR and help develop our self-funded plan. So I know I fit into the tribal category for my sector, but you know, a lot of times when you get somebody from the tribal sector, we have that broad knowledge of other programs. So I really am excited to be here to share some of that and be a part of this work group. So thank you for having me.
And thank you for, I know you do have a lot on your plate, Vicki, so thank you for fitting some time for this in. It's great to have you. One last super important announcement. Today is Shane Mauford's birthday. I know that there's no better way of spending your birthday than being with all of us. So let's all just kind of wave our hands and say happy birthday, Shane. And now I'm going to turn it over to our birthday guy and also Nora Leibowitz to just center us today for our breakout discussion shortly. So Nora, Shane.
Great, thank you, Jamie. This is Nora Leibowitz from HMA. And so we're going to do a really quick 3-slide discussion of these approaches, these straw approaches. And we think that you are all prepared for that because we know you have watched the video that had a discussion of these, that had a discussion of both the models and the actuarial kind of what's the world now and what would it look like under these. So you can go to the first model. Which we're cleverly calling option A. And that model is a universal coverage model that is administered by the state. And this is Universal 1. And the idea is that this would be a program that would be for all residents of the state and would cover both people who are citizens, people who are documented immigrants, people who are undocumented, as well as for residents, no matter what their current source of coverage is, whether or not they have coverage, et cetera. So it's really it defines the universal. And for this program where the state is administering, this is the one with the most state engagement. The state would define the benefit package that would apply for everyone. It would also set the rules for the delivery system, and that includes promoting primary care, encouraging the use of value or requiring the use of value-based payments, et cetera. Kind of how does care get delivered and how does it get paid for? And in this one, there are, unlike today, there are no health insurers involved. It's just the state working directly to contract with providers. Providers would maintain their practices as independent practices. It's not envisioned in as an England style. They're not employees of the state. They remain independent, but they would contract directly with the state to provide services for the Washington population. Quick note on a potential variation, which is the program could cover everyone in the state other than people who are currently eligible for one or more federal coverage programs. And the big ones really are the Medicaid program for low-income folks, Medicare for adults over 65 and those with disabilities, as well as some other programs that cover folks in the state, like insurance for federal employees and coverage for veterans. And the idea would be that in looking at this, all the other rules, all the other setup would exist as in a universal one, but that population of folks would maintain what they have now. So do we have any actuarial input on this one before we move on?
And I'll chime in after the next slide, and I'll make a comment really about kind of some of the key differences between the two, if that's okay.
Okay, great. So option B, which is also a universal coverage program, really differs from option A in that although the state is setting up the rules for the program, the state is not administering the program, and really that gets at the bottom bullet, which is that the health insurers, as they do now, would contract with providers, and so the state would have contracts with the health insurers and say, yes, you can do the administration of this. But similar to option A, it's available to everyone in the state. And just because this came up in one of the questions that we got, when we talk about state residents, we're not talking about coming to prove that you exist. It's just a way to talk about all Washingtonians, regardless of current coverage and regardless of citizenship or immigration status. The state would continue to define the benefit package and would still set the rules for the program, but then would, unlike in option A, would say, okay, insurers, you're going to organize the payments, you're going to process the payments, et cetera. And similar to the one we just talked about, the potential variation would be for all Washingtonians except for folks who are eligible for some or all federal coverage programs. Shane.
Thanks, Nora. So you might be asking yourself why we have two models that both have the same type of access for individuals. So for someone getting insurance, it kind of looks the same. But the key differences between these models in terms of how the program is administered, it actually has really significant impacts on the delivery system, potentially on the economy, who, to use one example, might lose their job or not lose their job based off of how it's implemented. So I think it's really important to consider not just how people are getting the insurance, but also how the delivery system is structured at a high level, because it'll have a really big impact on how you would try and roll it out and what the impacts are both on individuals, companies, and the overall economy.
Great, thank you. So for option C, which we're calling fill in the gaps, again, very creative naming. This is coverage for people who, looks like lack is, the word lack is missing, so it is lacking lack. Coverage for people who lack affordable access. And this comes out of having heard about the desire to find solutions that work for more people in the state, and looking at potential ideas that aren't as big a change as the universal coverage would be. So under this program, it would be Washington, people living in Washington who don't have federal coverage and don't have employer-sponsored coverage. So that's people who are buying on their own, people who are uninsured, and could include people who are buying through the exchange, particularly, some folks are using the exchange to get access to premium tax credits to be able to afford coverage. And this is familiar to a lot of you from Cascade Care, where the state is defining the benefit package, and in this case, it's it really is the essential health benefits, and that the state is also setting the rules for the delivery system and saying, how can we make a healthcare program with rules that really work for optimizing people's health and taking care of people. So in this case, as sort of set up now with Cascade Care, carriers that meet the requirements to participate can participate, and they would contract directly with providers. And just noting real quickly that the potential variant on this would be adding state subsidies, adding additional premium support. This is something that the state of California has started to do, so that, and they do it through their exchange. We will want to talk some in the Fill the Gaps discussion about how that works, and what does that look like for who gets it and how much, et cetera. So this is a very quick overview. We recognize that, but since you all listened to the pre-work, hopefully this is just a review for you. And we're going to have a chance to talk about each of these and ask questions and have discussions in the breakout groups. So, Jamie, tell us what happens next.
Okay, this is the exciting moment. So we're going to move into our breakout sessions. Before we do, I just want to give you a quick, and Liz, you can stop sharing your screen and we'll just be able to see everyone if you like. I'm just going to do a quick overview of our purpose for these discussions, and then I'm going to tell you how it's going to work. Our purpose, as a reminder, is not to determine the final recommendations to the legislature. Rather, it's that last step we need to take toward clarifying and confirming the models that our actuaries are going to analyze, so that they can get those outcomes to us in September. So please keep in mind that our objective at this stage is to set the stage for an analysis that will yield useful information for healthcare decision making. Since this is about what we model rather than what we are ultimately recommending to the legislature, you may find that you are discussing and working with your colleagues on a model that isn't necessarily your preferred approach. And so I just want to take you back to what Shane said in the pre-recorded presentation, that we are asking you to look at these models and discuss them from a multiple perspectives. Now I'm just say a few words about our approach today so you know what's going to happen. There will be 3 virtual stations, and each station is going to be dedicated to one of the 3 draft or straw models for healthcare. Each virtual station is going to be staffed by 1 or 2 facilitators / subject matter experts and someone from Optimus, our actuary. Workgroup members are going to be divided into 3 prearranged breakout groups, and each breakout group is going to proceed through each station. So you're all going to have, all workgroup members are going to have an opportunity to discuss and propose refinements to each of the 3 models. Now, members of our public are going to be assigned to one of those breakout groups, the one that's going to stay in this main room. So you'll be at the members of the public, you'll have the opportunity to observe all the discussions about all 3 models in this main room. TVW was going to be live streaming, but we understand they're having some problems with their live stream camera. So we are recording all of the breakout discussions, and they will be posted to the HCA website when we're all done here. Everyone's going to be sent to your pre-assigned breakout group automatically. So you may see a pop-up on your screen, work group members that say join breakout room 1 or join breakout room 2. Some of you aren't going to see any pop-up at that point. That means you're just staying in this main room. But when you see that pop-up, that's all you have to do is click yes, and you should be sent there. The facilitators and the actuaries are the ones who are going to rotate, and that's going to happen every roughly 30 minutes. So you don't have to do anything. You just need to bear with us for a minute or 2 as we get shuffled around. You may see a note that says that the facilitators need to leave the room. You don't do anything, just stay there, and your new facilitators will be joining you. After we've cycled through all 3 stations, everyone's going to return to the main room for a report out, and the intended outcome of this report out is that we're going to hear the highlights, the key themes, and even some outliers that came up in the breakout room discussions. And our intent is to confirm any final revisions that we're going to make to these draft models so our actuaries could go ahead and start their work. I'm going to send you off to your breakout groups. I see that there is a hand raised from Aaron. Aaron, I'm actually not going to take questions now because we need to go, or comments. I sent you a chat, actually. I might not have seen it, but thank you. But there will be an opportunity when you get to your room to make a comment or ask questions. So I think we're going to hit start now. Liz, New York Liz, our wonderful Tech person, can you send us to our rooms?
Hi, this is New York Liz. Janine, I believe you can begin your session.
We can't hear you.
Janine, it looks like you're not logged in on audio. You're connecting, perfect.
Can you hear me now? Yay. Okay. It said I was on, but it wasn't. So Zoom dynamics. So this, you all are one group that's gonna, and Shane and I are gonna rotate out in about 30 minutes or less. And we're going to tackle looking at the first model, the state universal model 1, state administered. The idea is that we make sure there's any questions about the model as it's currently laid out. Hopefully you all have did the video pre-work so you understand the discussions around that. And then I have a series of questions that I want to ask you. Some of these questions apply probably to both Model 1 and Model 2 because both are universal, but we sort of split them up and sort of thinking about them just due to the lack of time. But we want to make sure all of you get a chance to do some thinking about this model. And then at the end, we're going to come back as a large group and be sharing some of the themes we hear from each of the 3 groups as they wrestle with each of the models. Does that make sense to anyone? Anyone have any questions? You can either use your raise your hand, or you can just talk, or we'll see how this goes. This is always a pilot here. Or you can raise your hand and I can see all of you at this point. So this model, as you may have read, was where it's participants by all residents. The state defines the benefit package and the state sets the delivery system rules, and there are direct contracting with providers without health insurance carriers. So I wanted to step into whether there were, and then there was a variation that we'll get to in a minute. So were there questions about this model in general before I launch into some questions? And I don't know if you guys can all unmute yourselves if you want to talk. So it looks like you are all muted.
I'm able to unmute myself.
There you go. Good. Okay. You should have. So Dean, you're still muted. Were you going to say something?
Oh, no, I was just,
go.
I have the ability to unmute.
Okay, everybody knows where the unmute button is. Okay. So the first question is, we wanted to understand, so if this one is participation by all state residents, would there be a model have a mandate for insurance coverage? And why or why not? Thoughts for this particular model, Model 1A, universal coverage, state administered? Kelly, I can't hear you.
Could you repeat that question again? I apologize, I was distracted.
Okay. The question that would be helpful to the modelers is, would there be a mandate that one would need to participate? It's available to all Washington residents, but should there be a mandate associated with it that you must, similar to some of the ACA originally?
I guess one comment I have around this is, as part of it, thinking about, well, how would you enforce the mandate, given how at the federal level, when we had the individual mandate, you would disclose it on your federal income tax, but here in Washington, we do not have that. So just thinking through the mechanics of how would people declare they had the insurance, and how would you enforce it? And what are the penalties associated with it too? Would they be significant enough that it would encourage people to get coverage, or would there be minimal penalties where if you had, for whatever reason, be like, oh, I'll just pay the penalty rather than getting coverage?
What do some others think about a mandate?
It almost seems like you would have to have a mandate in order for it to work. Because if you had some people not join, but then others join, I guess I just I can't envision how it would work if everybody wasn't automatically a part of it. Maybe you're just automatically a part of it, not necessarily a mandate. I guess that would depend on the cost to be a part of it.
I guess that would be similar to Medicare, right? Where we are all eligible for it at a certain age. Is that what you're sort of suggesting there?
Right, right.
As opposed to the ACA mandate where you either join or you pay a fine.
Exactly.
Different. Other members have thoughts about this? Kelly?
Yes. Well, if you don't have any other choices, then by default, so it's a very different climate than ACA, because in ACA you have different choices. But we're saying in this example, if I understand correctly, you're either on one of the federal programs or you have this, and those are your options. So you gotta have to just go. I don't even know if you have to say anything about that.
One way you could think about it is it's like car insurance, where if you have a car, you're required to purchase it, but not everyone does. Some people absorb that risk, not wanting to pay into the system. So, for example, if this system does have a company structure or a premium structure based off of your income, if people have the option not to pay into it, they might take that risk. So this question of a mandate actually can be pretty important, because, for example, if you have members that incur catastrophic costs, but they didn't sign up for it, they haven't been paying into it, you know, what happens with those costs and what happens to that individual? So I think that car insurance analogy can be helpful.
There's some assumptions in that, though. You're talking about how it's being paid, and are we talking about that right now? I'm confused about that.
Was there someone else going to say something?
Yes. This is Don Hinman.
Oh, there you are. Okay.
You're hearing me?
Yes.
Actually, the simplest way would be to declare every resident of the state of Washington covered. The issue then would be how you pay for it, and do some people pay less, some people pay more on ability to pay. But the only way you get by making sure everybody's covered is just to plain declare at the beginning, everybody's covered. And then the issue becomes, how do you pay for it? And that's the rub. But I think that's really easy to solve too. You just you figure out a way of taxing people, and that's the way they get paid.
Oh, go ahead, Rich. You're still muted though.
I just can't imagine a mandate. I can't see that we have any enforcement mechanism. I agree with Don. They just have to be signed up, and we'd have to find some way to roll in the revenue. The problem is, and I think we should get our head around metaphors, because when we use the driver's license, the car insurance thing, it's all fine and good, but we just need to remember that the option for someone who chooses not to get insured is to just go bare and hope that you don't get an accident or the cops don't pull you over. There's no prospective way of really dealing with that, and we'd be in the same exact situation if we try to go down that mandate route.
Because I think that raises the question of some of our other questions is, is there ability to buy supplemental insurance if this is in place? So imagine the world with universal coverage, everybody's in it, be it automatic or through some other mechanism. Would they be able to buy insurance on top of that? Would they, maybe something to help reduce their cost sharing or enhanced benefits? Is there still a marketplace for insurance outside of this?
Yes, there is. And it would be really easy to do, just like you do with Medicare supplements right now. And you would just name the basic coverage and have everybody covered. And then there would be a market through the private markets to provide the additional coverage.
What do others think about that?
For a universal plan, I think there's a danger of having high-risk individuals either being biased into the pool or out of the pool. We talked briefly about the notion that if those who are taking the risk of not joining, having a catastrophic disease, that really can throw the system. On the other hand, if people who are healthy opt out of or choose not to go into the system, then it leaves a higher risk pool inside the so-called universal system, which again skews the math.
I think we're being confused with what insurance is today, and that's, you're talking about adverse selection. And if everybody's covered, then everybody's in the pool, whether you have a high risk or you're not ill at all. And that's the only way you could do a mandated system. And it's so easy to do if you do it that way. Otherwise, you get into all these complicated things about adverse selection, and that's what he's talking about.
Oh, can I get in the conversation?
Go ahead, Sybil.
I wanted to ask, I think from some of the materials I saw earlier, we were thinking, or there was some thinking that there would be premium share or cost sharing. And I guess I would just be curious about that. I think that's an important part of this conversation as well, because if you create a product that is so irresistibly good and, great access, great price, or like no price, I think that a mandate won't be needed. I think it'll be a no-brainer for people. So I guess I'm curious about that. Like if I don't know if as we're giving questions to the modelers, if they can look at different options within each category, but I would be really interested to see if there was no premium, for example, so that you could just declare everyone was in, what would the cost sharing look like? Would it be a valuable insurance product if you just made it so that people didn't pay a premium and that their costs were coming into the cost sharing part? Or conversely, if there was like very low or no cost sharing, what would the premium look like? I know it's a balance of the two, but I guess I would just be curious about what the extremes would look like.
So, yeah, Shane, you want to comment at all?
Yeah, just kind of thinking that through on the fly. I don't think it's problematic to look at different modeling options at all. Where my head's going conceptually with this is that if you put all of the patient share of cost into like the co-insurance and deductible versus premium, what you're doing is the people that get sick end up with the financial burden, as opposed to when you're paying for premiums, it's spread across the broad population. So you get pretty, I think, wildly different outcomes, and I think that there's considerations for both equity and, you know, if the people that are the ones that might also be the ones that are unable, and there's a little feedback. If the people that get sick are the ones that have the financial burden, they may not be able to pay. So that could destabilize the system as well. So just some preliminary thoughts on that from a modeling perspective.
This is Vicky. Can I ask something? Sure. So I'm a little confused because I think the question was about them, you know, whether it's mandated, but I think the question that's not answered is how it's paid for. And I think the answer is different based on whether or not it's paid for through taxes and everybody's just eligible, as opposed to paying a premium monthly, which I think would be harder to get people enrolled in. Right. So I think that question, how is it paid for first, might be a little bit more helpful to answer the mandate question.
Somebody saying something? Am I missing? No. Well, let's move on. So we talked a little bit about substituting or supplemental, and there was the proposed, you know, possibly something similar to Medicare, others. What about the federal program? So variant 1.5 was, it's everybody unless you're in a federal program, Medicaid, Medicare, a federal employee. So thoughts about that when you guys were going through this? What do you think? Should any of those federal programs be entwined into what Washington State wants to do or not?
This is Vicky. It's okay if I talk? So when my tribes, we started a program based on insurance coverage for tribal members in the 90s, and we bought insurance for people, but if they had Medicare and Medicaid or employee insurance, we figured out how to work around those coverages, and we did it in a way that was more cost effective. So I think if there's something else that somebody's eligible for at the federal level, not counting Indian Health Services because that's not a coverage, that we should take advantage of those dollars, and maybe if there's a way to wrap around coverage for things so that everybody can still have the same level of benefit. I know that sounds complicated, but I know how to do it.
That's exciting.
It sounds like what though you were doing was wrapping around their existing other benefits. I think the question here is, do we fold in the Medicaid program into this universal project program, with part state, part federal, as one example? Do you try to get the Medicare dollars, which I know from my work here in Oregon, we have a governor that has tried for doing that for years. So the question is everybody on the same Washington universal coverage, or do we have everybody unless you're in one of these programs? Or is there one of these programs, similar to some of the questions we asked on our survey, that you would really want to be folded in, and figuring out the logistics of it? Kelly?
Yeah.
And then
I guess what concerns me about, I would love to have our own Washington brand of healthcare and have it be for everyone, but we all know that requires a federal waiver, a substantial federal waiver to make that happen. So I personally would be interested in allowing the federal systems to stand as they are, and then everybody else outside of those as described in the variation. And I am interested in that, just as a workaround to the problem of the impasse with the federal government.
Jeanette?
Rich?
Yeah, I ditto what Kelly's saying. We wouldn't have a 1.5 plan presented to us if really the subtext here is that there's no reasonable chance that the waiver is going to be obtained. We can follow the lead of the states that have been trying for much longer. It's just not going to happen. So the 1.5 thing seems to be the plan that would need to emerge for the legislature to consider. But I would point out the advantage of having the federal plans at this point is that we, if we're going to solve this mess, it's going to have to be through cost controls as well as access. And the structure that happens here is that these federal plans actually have a fair amount of innovation, evolving innovation that has our only real chance of bringing down costs into them. So striking them out is not a great idea. The MCOs, for example, have to compete to innovate to bring down costs. So I think that's the vision we need to do that. If we can't, no romance without finance has no chance. And I think that that's the way we're going to bring it down, innovation. And I think we need these federal programs and not think of them in negative terms as wasteful products, especially Medicare Advantage, et cetera.
Sybil? And then I think Don had his hand up earlier.
I would just say, I don't know if this still holds, but my understanding was that we need a lot of money in the pool to make this work. And from what I'd read previously, you really need the Medicaid, the Medicare dollars in a pool to make universal coverage work. Otherwise, it's not clear to me that there's enough money to make it a valuable product that would actually provide coverage people can use and that they want. So I guess that would just be a question for the modelers. Is a 1.5 even a viable or helpful thing to offer to people?
This is a legitimate question.
Michael?
Yeah, can I make an observation? One of the challenges with the federal programs, Medicare and Medicaid, is their reimbursement rates are so much significantly lower than what negotiated prices are now, that many providers tend to limit their access to patients on those programs. And if those programs are kept out separately so that they're basically, I don't want to say competing, but they're in parallel with our Washington State healthcare plan, and providers currently claim that, at least on Medicare and Medicaid, in the testimony we heard at the Cascade Care discussion, that they only cover about 85% of their costs, then providers are going to be looking for mechanisms to limit access for patients on those programs unless there's equal compensation across the board. And I think it was, Richard was talking about other states that have tried an all-payer rate, which at least levels the playing field and eliminates that problem of preferential access. I think that's one of the considerations that needs to be included when we talk about having, whether we have Medicaid in or out of the Washington program.
And one of the issues related to some of this interaction with the other federal programs is benefits. So I want to move, because we have about 10 minutes till you're going to shift over to another model for discussion, is a lot of the feedback we got and in the discussions before and in the survey were the essential health benefit package of Washington as kind of the base benefit package. It does not include some benefits, including adult vision and dental. So should this new model, universal, include those? There's some enhanced benefits that Medicaid often covers that are more enhanced. Does that apply? Do you want those in? Some thoughts about benefits do you want to discuss for a few minutes?
I would say that you should include all of the benefits, eye care, dental care, and from being years on being a foster parent, I can tell you those two items are really what holds people back, is the lack of dental care and eye care. And the other thing is to kind of talk about it. When I'm an insurance agent, when you talk to employers, they would love to fold in labor and industry health benefits. They talk about that all the time. And so that's another source of revenue. But I think the person that Michael, when he talked about, I know doctors selecting against the system if he didn't have uniform payment benefits all the way across. There's no way to avoid that. And so people would be excluded if you left the federal programs in at paying a lot lower benefits.
Others have thoughts about benefits, primarily those that are not in covered. We have children's vision and hearing are covered, and dental are covered in EHB, but it's the adults that is what many plans don't cover. Rich?
Can I clarify really quickly? What about pharmacy?
Oh, sure.
Is pharmacy part of the benefits that would be included in there? Because that is one of the most expensive pieces of healthcare.
Right. The essential health benefit does include prescription drugs. Yes. So we tried to identify the benefits that were not there, which is usually the challenge, and discussions are always about adult dental and vision. Rich, you were going to say something? And then Kelly.
Yeah, it was just clarification. The other three that need to be dealt with explicitly, whether it's in the essential benefits or not, are chiropractic, naturopathy, and long-term care.
Right, and those were on my list as well. Thoughts about that from this group? It sounds like, Rich, you would advocate to include those alternative, what sometimes is considered alternative treatment.
Yeah, I think we want to, there's a huge constituency for all three of those groups, and we want this to be widely supported, and the public wants those services.
And
Yeah,
Kelly, I think you had your hand up. Oh, Sybil. Let's go with Kelly because she had her hand up before, and then Sybil. You're muted.
Trying to be good. Myself muted.
Yeah.
Let's see. I was going to say that one idea that I've seen in some plans that have been put forward is just to say if we reimburse any medical professional that's certified by the state of Washington. So that would include chiropractors, naturopaths. That's just something to think about. But my main question, though, is when will we have an opportunity to really get into granularly these different options? I think it sort of tried to happen in that straw survey, but I had a ton of questions about the different options there and the merits and disadvantages and advantages. I mean, so is this the opportunity, or will there be another opportunity for us to really learn about what those things, what the possibilities are, and advantages and disadvantages of the different options?
Well, we synthesized all the past discussions and the survey into these three, what we call straw models. And then this is the first opportunity to try to help start to refine those models, so then that Shane and Jared as optimists will start to flush out those models a little more, bring them back to the group for further discussions.
I guess I would like to provide some comment that some feedback that we really haven't been given very much time to do that in a very organized kind of way. And I would really like to see an organized way of looking at that and discussing it and going line by line down and hearing from the other members about what the advantages and disadvantages are to the different elements. A little hodgepodge conversation, it just makes me nervous that we're trying to design something based on that in a kind of random way. So that's my 2 cents. Thank you.
Sybil, you were going to say something earlier about the benefits?
Oh, yes, thank you. I was going to say about long-term care, just really advocating that that be included. I think that is a service that if we're, if we have the chance to live long enough, many of us will need, but most of us are not prepared for. And the insurance system for that is not great. I know that we have some new legislation put into place in our state to help with that, but I think there will still be gaps. So that's really critical.
And do you think that because there's new activity going on in that's something that you would want out of the gate, or to wait until that gets stood up the new legislation, and then
That's a great
or
question.
do you
I think
or
I would
think it should be priced into the model out of the gate?
I think it would be great to be priced into the model out of the gate, taking into consideration the Washington legislation and knowing that some of the costs will be offset by that.
Raise hand.
Yeah.
Comment. Can as a citizen consumer, can I comment on the benefits discussion?
Go ahead.
I know that one benefit, I also agree with being universal for including vision and dental for adults. As a displaced worker and now one with disabilities, I was offered COBRA, and I don't know if there's been discussions in your group recently on, are you going to use COBRA as an option? Because myself and many others I have found when I was going through that in the early 2000s after being ripped from my workplace, is that COBRA is not affordable to those usually under 40, 50,000 a year. And I don't know if that discussion has been made about COBRA as a benefit and working unpaid COBRA co-pays into universal health care.
All right, I'm getting the word. Thank you for those comments. I might disappear here in a minute, but you guys can keep talking because we're gonna get moved to your next group, or I'm gonna get moved to another group of you. So, so again, this is the beginnings of trying to refine and discuss and learn about these models. And Rich, you had something you want to add?
No, just very quickly, I did bring it up, and I really want to second what Sybil said, and I was watching the nodding of the heads about long-term care. From this group, I saw a lot of support for that, and it's not just because the public wants it. It's financially the only way to go. We're paying for it anyway down the road in spend down and poverty and Medicaid. So I think I'm still seeing nodding heads, but I think that should strongly go forward with that language.
Duly noted, and I'll be sure and get that down. So Shane and I are going to disappear, and you guys are going to get moved on to another model to be discussed, and some of these will come up again with one of those models that's very similar. So I'm moving on.
Thank you, Janine.
I have a question for the group. I wonder if there'd be interest in seeing have the actuarial people do some of the options with prices so that we could see everything, and then we can continue with that when we see it and decide what kind of recommendations to make moving forward. Because of course I want long-term health care, but it's really expensive, for example. Or I feel like I need the full information.
Kelly, are you suggesting that when they model that they modularize to show an option with or without long-term care factored in?
Yes. And yes. Thank you.
Yeah, I think that makes sense. I kind of wonder about that for a lot of these benefits. I think it's really hard to have this conversation without all the information, like you're saying, Kelly.
Yes. Yeah. Thank you. So,
But we need to have the actuary calculate out what we're paying anyway.
Yes.
You know, the person that has no coverage, I take care of people in the hospital. They, for lack of better words, they rot for 3 months because no one will take them because the entity doesn't like the bed rates. But making progress on this, standardizing the benefit, standardizing the payment is probably the only way forward, and regulating the industry.
Rich, I agree with you. It's got to be balanced not only with the cost of the benefit, but the cost we're currently paying anyway.
Right.
Which, yeah, I totally agree with you.
I'm hearing from a lot of managed care organizations that are struggling with that as they want to move beyond integrating physical health with mental health and dental. They're saying that they missed public health as a real serious issue, and the amount of underfunding that happened on the public health side is being experienced at the MCO level when they're on value-based payments or under capitation. And so moving forward, there's this huge desire to ensure that oral health, mental health, physical health, and public health are all considered under the coverage. Just a benefit issue.
Hi, folks. This is Nora, and I hate to cut off other conversations, but I wanted to jump in and make sure that we have time to talk about option B, the Universal Healthcare Distributed Administration. I put up on my screen the notes from the prior group, possibly as a way to kind of give people a sense of, if you want to just say, like, if you have something to add, we of course want to hear it, but if you would prefer to say, like, oh, I really liked what was already up there about blah, 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 etc. Because in this half hour, we have 3 topics to talk about. So I'm going to start with the little reminder about what this model is, and then we can get into what the topic areas are. So under this model, all permanent Washington residents receive health insurance coverage through a single statewide health plan. The state delegates most financial risk and payer-related functionality and delivery system management to private insurers. There's a single source of coverage that's administered by multiple organizations. The providers remain private. This model could be seen either as an end state or as a transitional model as the state migrates to a fully state-run model in the longer term. The model partially protects the existing infrastructure, jobs, technology, boots on the ground experience, et cetera, but also preserves the existing market fragmentation. So this is one of the 2 universal coverage models. It's the one that keeps insurers. And the 3 topic areas that we want to talk about are first, one that impacts both this model as well as the other universal coverage model, which is about cost sharing by participants. We then also have questions about the level of autonomy versus standardization in terms of how much the insurers can define and will be defined at the state. And then thirdly, we have questions about whether folks see this model as an end state unto itself, or as a stepping stone toward more fully state-run modeling. So just keeping in mind that that we have those 3, and I am trying to see who all is in the room. What has been helpful, since I'm trying to take notes and make sure that we get to everyone, Jared, can you play Traffic Cop?
Yes.
Okay. So I don't know how you all did it before, but we found it pretty helpful for people to either literally raise their hands or to use the little hand raising button, so that Jared can see who wants to chime in and people aren't talking over each other. So let's talk a little bit about cost sharing. And that is whether people think there should be any form of cost sharing, and that includes both the monthly premiums that people would pay to participate, as well as site of care cost sharing, like co-payments or deductibles, and I guess deductibles aren't pointed to. Anyway, and then if those types of cost sharing exist in the program, what people think about how that would be structured, whether it's uniform across, whether it's based on income, et cetera. So you can kind of see some of the things that folks have said, and I'm going to record all of your comments as well.
So, Kelly?
Oh, Kelly, you're still on mute.
Yeah.
I could speak up to kind of start it off. And one of the things I think most
looks like, okay.
Most problems with private companies in our clinic that we've had problems with is being able to get approval for certain kinds of treatments, delay of payments, all those things designed to kind of enhance the profit of the insurance company. And I think if you're going to use insurance companies, we understand the importance of sharing costs through reinsurance, but we don't really ever consider sharing profits. And if one company can have a significant profits, they shouldn't be allowed to keep those profits, but have to share them with the other companies, which keeps the overall cost of the system down. But there's a real problem when you use insurance companies, and I'm an insurance agent of companies designing ways to keep their costs down by delaying treatment, delaying payments, delaying access to specialists, and that's a real problem right now in the system that we have.
Kelly, I think you're back. Thank you, Don. I think you got unmuted, but go ahead.
Yeah, thanks. Sorry, I'll try to be better about that. I guess I'm still a little unclear because I thought that these systems were paid through taxes, so I'm confused about that. But if we are for some reason having cost sharing, I think it just must be based on income level. There must be tiered participation, including no cost sharing for some people who are certain federal poverty level. Thank you.
I mean, I think that this is really the question, right? It's like we know that each program will have a total cost, and so the question is the total cost funded by taxes or whatever state allotments, or is some portion of that paid through the participant? So it's really the question.
Hi, this is Vicki. I'm just thinking taxes are the citizens paying for the coverage, and then we'd ask them to pay again by paying co-pays. I think that's part of what's wrong with the system we have right now. Really, you pay a premium and then you pay the co-pays. It should just all be covered in the cost of the care. I know that that cost sharing is used to keep people from using their coverage, but I don't think we help ourselves by keeping people from going until they're really sick. And I think that's why like the 100% cost, the 100% coverage for preventive care under the Affordable Act was really important, because at least people are getting their preventive care.
Does anybody else have comments? I haven't seen anybody raise hands.
This is Don.
Richard looks like he's got something. Go ahead, Richard.
I just think, to be realistic, I come to this with the bias that realistically want to see something done, and 2.5 makes the most sense to me. But the line that sticks out in my mind is insurers that meet state standards contract to offer coverage under the program. And there's the rubs, the state standards. So the state sets the standard about co-pays and et cetera, and all the extra hidden costs and the delays in authorization, et cetera. There's certain standards and performance measures that need to be met, or you can't contract. You play by the rules that the public needs, and you're welcome to stay in the state. Otherwise, you'll have to go elsewhere. State makes the rules. HCA makes the rules.
Beth, I saw you raising your hand. It looks like you're muted, and we'll turn over to you, Beth.
Yeah, thanks. I am muted, and I agree with so much that has been said. And I mean, I think as you know, there is the opportunity to really incentivize and reward people for care who aren't seeking care. And so we do have, you know, a limited supply of providers in hospitals, and so do need to make sure that we would build in through some mechanism the appropriate level of care for the right folks. And you know, we certainly incentivize people for primary care visits and preventive visits, and we seek out people who have gaps in care and incentivize them, and sometimes incentivize the providers to get them in. So there is, you know, oftentimes paying people to go in for certain services that they need and make sure that they have for their overall health. And then there are those services that show less efficacy from taking care, and you know, those get pre-authorized or other things. So there does have to be some type of mechanism both to incentivize to get the care that they need, and just make sure that we're managing, you know, the pool of tax dollars, whatever it is, employer funds, that we're not expending that. So I think there does continue to need to be something in there, but it would be that whole continuum of let's get people in for these services that'll really help.
Kelly, it looks like your hands. Yep.
Yes.
Go ahead.
I had a question for clinicians in our group. Let's say I'm one of those people that just likes to go to the doctor because that's where I get my socialization taken care of every once in a while. What happens with those patients? I mean, how does the clinic respond to people like that? The overusers, I mean, yeah.
Richard, it looks like you're on mute as well. Just so you know, Richard, you're still on mute.
From a practical system point of view, the drivers to the cost problem conundrum are not primary care visits. It's the small number of people that just need it for their social lives. That's just not the problem. It takes up a little bit of capacity, but they're not the drivers of problems in any way. And the reality is, those are the folks that over time tend to get very important needs met, and even if it's social and emotional. So, but they're just not expensive.
So what are we talking about then, do you think?
I think if we're talking about, we're talking about low value care, cost benefit, from a cost benefit analysis. So it may be excessive numbers of visits to a primary care provider that don't seem like they're achieving much, but they're not driving the cost, as opposed to many of the procedural types of things that need to be restricted because they're low value care.
So I don't know if I can jump in.
Thank you.
I don't know if I can
go
jump
ahead.
in here. Am I able to be heard?
Sure.
My name is David Brook. I'm a retired physician, and I've got a few comments. One, in regards to what Kelly just asked, I think that with the changing dynamics of telehealth, we may see that there are opportunities to deal with what she's talking about in a different way and a different cost structure than we currently have. Secondly, in regards to enrollment, I'm on Medicare. I find Medicare coverage very good. Medicare does not cover dental and vision. If you bring Medicare people into your coverage for everyone, then you're bringing in a higher risk group. And whether you want to do that or not is something that I'm uncertain about. Lastly, in regards to charging according to income, I think that since we have the most aggressive tax system in the country, that charging people who have a higher level of income a fee more than people who don't have that level of income would be appropriate. And that would be a way to bring our tax system into our situation into a more progressive situation. instead of sales tax, people who have significant income might have to contribute more money towards their health care.
Thank you, David. So Vicki, it looks like you had your hand up and you are on mute, just so you know. There you go.
Okay, thank you. Sorry about that. You know, and in answer to Kelly's question, I'm not a provider, but I have worked a lot with our schedule at the clinic. I just think that sometimes people go to the doctor because they can't get the other services they need, would be behavioral health services. And so in a system where people have access to the care that they need, not just, you know, it's not just restricted to, I can afford my copay to the primary care doctor, then I think you won't see that as much. I mean, I would think if a primary care provider was seeing someone several times, you know, and it wasn't really a medical need, they would want to try and ask if they need a referral to a behavioral health specialist, you know, are there other services they're looking for?
Interesting, thank you.
Is it Micheline? It looks like you have your hand raised, but you are on mute.
Oh, were you talking to me?
No. Oh,
Okay.
I see your hand raised. Sybil, do you want to go? Oh, I know Micheline looks like she's trying to figure out her mute button. So why don't you go ahead, Sybil? Oh, now you're muted again.
Okay, sorry.
There we go.
Hi. So just in terms of cost drivers, I think a lot of them have been mentioned, but I would agree that one is low value services. Another one I'd say is like unnecessary price variation among providers is a huge one. So I think that this would help address that. Another one is people with dual diagnoses who are not well managed. So I'm not sure how this would address that challenge, but I think there are lots of things that could be built in to help support better care and treatment for people who need it. So I would say if this could tackle those three things, I think that would do a lot toward bringing costs down and under control.
Okay. Thank you. And Nora, it looks like we got a 10-minute notification. So do you want to move to any other topic or?
So one topic that that we haven't really talked about is this transition, whether this is whether people see this as an end state potential or see it as a stepping stone model toward option A.
Michael, you're on mute. You just got to unmute yourself. No, Michael, you're still on mute. There you go. Oh, you were off. There you go.
All right. Yeah, I couldn't unmute.
All right. Okay, let me just talk about, I'm a little confused about this plan here. And we kind of skipped over the autonomy versus standardization. And there's a basic question in here, in my mind, about the health insurance companies and what role they play in an ultimate plan, and you're talking about whether it's a transition or whether this is a final product. There are a lot of the European systems that we've tangentially referred to that still keep their insurance companies, but get out of the business of the competitive for-profit motive that it sounds like is preserved in this model here. If we can buy for contracts, I think the only, several people have commented, I think Don made it, comment that if we improve the quality and systems, we're going to reduce costs, but also if we cut out useless competition and inefficiencies in the insurance industry by simply making them conduits of the fees that are set by the state and cut their overhead down to the 3 to 5% that's common with the European systems. We can keep the insurance companies in this, but not have them contribute to the cost as they currently do. And they're helpful in terms of being those conduits and in terms of providing the accessory policies that are necessary for some of the things we've been talking about that may end up not being covered in the final recommendations. But if your question is this a transition or is to a state-run program, I think this model, Model B, can be a very effective option as long as there is control of the rates of reimbursement and the premiums that are charged by the state itself, and not leave that in the hands of the participants to dicker over that. We need some central control of the costs that should be part of this, and if so, then this option B is probably the best way of handling it, the least cost in terms of we don't have to recreate another bureaucracy to handle the monies that flow through in premiums or payments to the providers. And we have a supplemental services available that may not be covered by the ultimate plan. So I think with modification, this plan would be an ideal one, and I'd love to see the actuarials talk about what they could do about covering costs if we end up with basically the state setting the rates as the single payer, but keeping the insurance companies as conduits for the money.
Thank you. So I think we have about 5 minutes left. Are there any of the other work group members that have any comments they'd like to make? Beth? And then after Beth, we'll go to Kelly. You're on mute, Beth.
There we go. This is just a question, a clarification. Does this model suggest there isn't employer coverage? That everyone is covered through the state?
Right.
Yes.
Because I just, with all our large employers, you know, Microsoft, Amazon, Nintendo, who use sometimes benefits as a recruiting option and retention, I don't know how successful we'd be in having large employers opt into this when they're multi-state and that. So I don't.
That's okay. Kelly? And then Kelly after you, Sybil? Go ahead, Kelly.
I guess I could see this being a stepping stone option, particularly in a transition period to option one. That is one role it could play.
Thank you. Go ahead, Sybil, and then we'll go to Dawn after you.
Okay. I would agree with Kelly. I think if this plan were to be used, I think it should be as a stepping stone. And I would say for both of the universal options, I think that from a labor perspective, we would be, benefits are really important to us. And we've spent decades fighting for good health benefits. I think that the place we've come to on this is that as long as there's a possibility to offer supplemental benefits and there's no prohibition against that, I think that we would be okay with it to ensure that we can, that there is a possibility for additional health benefits on top of this universal standard for everybody.
Thank you. And Don?
I just want to agree with Michael that if you use the private companies, there's a lot of flexibility that's available that companies can do, but you have to take the profit incentive out of it, or you just have a system where it keeps building and building costs. But on cost sharing, I'm a small employer, and one of the big problems I have, my employees are fairly high paid, but they also have really high deductibles, and I can't get them to go to the doctor when they really need to. And I've had several times where employees have used up their entire deductible, and I can't get them to pay their deductible, so I end up paying it for them to avoid them to go into collection. And I really think you have to eliminate deductibles and co-insurance. And at the health clinic where I'm involved, there's some ways you can handle people that keep showing up to the doctor with just for social things by referring them on to places within your clinic that can handle them really easy, and we just have to get used to being able to do that.
Okay.
So how about one more comment, and then we're getting, Jared and I are getting the hook, so. Jared, I don't know who was, if Michael or Richard was our.
Let's go with Richard first. Good, Richard. You're on mute.
Yeah, just to be clear, I mean, I haven't heard anybody saying this is the end product. I think we're putting forward the idea that this is a stepping stone. There's a chance that it could work. But if I'm in the legislature area, that's the language I would be hearing, that this is worth a try. And if it doesn't happen, then we have to do something else, probably to get towards number one. The issue of the large employers is so critically important, but just because that seemed like something that's insurmountable now doesn't mean it would be insurmountable next year, depending on an election. So changing things at the federal level in ERISA to be able to bring the large employers on board and make it in their interest to do so, because they can compete on plenty of other things other than benefits. So I think it's a stepping stone that we're putting forward.
Okay. And then it looks like, Michael, you have your hand raised. I can't unmute you. I'm sorry. I don't know. I don't have the capabilities to do that.
Okay.
Thank you. Yeah.
I'd like Micheline to get a moment in because she hasn't talked yet. But to do that, you have to unmute.
The host will need to okay, you hear me? You hear me? Okay.
Yep.
I wrote a comment to Jared. I was just wanting to say, I have noticed many I've talked to that primary care clinic stock providers, some provide sliding scale payments, but for the low income or even some moderate incomes on the low side, it's still unaffordable. And I haven't noticed that many, there are a lot of primary care clinics that still don't provide like installment plans. And maybe that could be like established as an option that might be used more, as make it easier for people to get into primary care providers. And like you were discussing about those that might want to keep making appointments with a primary care, that way might be able to screen out those that need the mental health services or whatever kind of services that they are trying to get that they can't afford. Is that?
Yeah, that's great. Thank you. So I've just gotten a message that we have a 5-minute break and we'll resume at 2:45. I don't know about the rest of you. I would like to run to the bathroom, just to be perfectly honest. So depending on how desperate you are to talk, David, we're happy to get your comment, but then I really want to take at least 2 minutes to run downstairs. So talk now or forever hold your peace. Okay, you're talking, but you're on mute, so I can't hear you. I currently see both Michael and David talking, and I can't hear you.
Yeah, everybody's still muted.
Okay, I think I think at this point we just need to, like, you can write an email and it'll go to Jamie and we'll include it in our thing. So you all have 5 minutes at 3 minutes now. At 2:45 we are reconvening. Sorry, okay. I promised I would give everyone a bio break.
Okay. Thank you.
Hey everyone, looks like we're all rolling back in here. While we're waiting for everyone to return, I'm going to make a request that if you are a member of the public that you please turn off your video camera. Just makes it easier for me to see the work group members and call on them. And if you're a work group member, please turn on your camera. Thank you. Appreciate it, everyone. Let's see here. Great. All right. So I'm just going to make sure I've got my team back here.
Jamie, do you need anything from me?
Just your brilliant note taking, I think.
Also, just a reminder, if you're not a work group member, please keep yourself on mute.
Okay, let's see. So I see Dean and Dawn and Dr. Kovar and Representative Macri. Hi, Kelly. Let's see, who am I missing here? I see Beth. Hi, Beth. All right, let's go ahead and get started because I want to make sure we use all of our time together. This is, you've made it to the third discussion group. This is when we're going to discuss the close the gap model. And I'm not going to go through the whole preamble because I think you've already heard this twice, but all my questions are going to be specifically focused on the close the gap model. Again, if you could be as specific as possible in your feedback, that'll be the most helpful to us. Just a reminder that this is a model that closely parallels the cascade care model. Individuals who lack access to affordable coverage options and have incomes below a certain threshold would be able to access subsidies for certain plans on the health benefit exchange. And these individuals would be able to obtain coverage with lower premiums and lower cost sharing. So that's the gist of this model. And my first question for you is, what is your initial feedback on this model? This is probably the broadest question you've gotten all day, but when you saw this, what was your initial thought? No. Kelly. Oh, see if we can get you unmuted here. There we go.
Thank you. It made me sad. It made me feel like I'm just gonna have to be, I felt like we're always gonna be running and struggling to try to keep the costs down. It's just hard. It's not gonna work. It's gonna cost too much. It's just a patchwork. It's just a Band-Aid. It's such a waste of effort and energy. It made me very sad.
Okay, so your disappointment in this model was that if you felt like it didn't address any of the issues that we've been highlighting as problems with the healthcare system.
We just can't get ahead of anything. We're just always like, that feeling of like just
hamster wheel.
Yes, yeah, just trying.
Yes, and I will share with you that your feedback is very consistent with what we heard from others in the other two groups that we've facilitated today. So that's some pretty common feedback. Other reactions?
Sorry.
Okay. Dr. Kovar. Let's get you unmuted here. Hold on. There we go.
I think it's really saying the same thing, that it just doesn't, I just don't see anything in this that would help or coerce to bend the cost curve. Though we have to remember that the charge of this is a universal care, universal coverage. So should the legislature decide they want everyone covered, this isn't a bad thing to fully flush out. It's not fully understanding that it doesn't help to do anything to control costs.
Okay, so you're saying that this doesn't necessarily change the system and the way we're looking, but it could potentially address the universal coverage.
It could make it worse if the premium ultimately is so much less than other sectors. It will create a three-tiered system of healthcare, which is the last thing we need in this state.
So you're concerned it could exacerbate things potentially. Okay. Okay, Kelly, I'll come back to you in just a second. I want to make sure I give other folks a chance to weigh in. Sir, I'm calling on work group members right now. Members of the public aren't going to participate until we get to the final comments. So I'm going to just stop your video there. Thank you so much. Other work group members, any feedback? Okay, I'll give the floor back to Kelly here. Kelly, what else is on your mind?
I was just going to say, I'm happy to get it costed out because I know what it's going to show. So I have no problem including it in the versioning because it's going to be to my benefit. So I'm happy about that.
We heard that as well in a couple other work groups. That was very similar. We need to have it to compare.
Yeah, yeah. I think they expect
it's what the legislators are going to be. That's their home base. That what they're going to want to think about first. So okay, let's get that all answered and detailed out.
Yeah, the feedback we heard previously was that folks expect this to be the most expensive option. Okay, before I move on, any final feedback on this one? Any final reactions? Anything different from what you heard here? Okay, here's a question. Should this model be open to all Washington residents regardless of immigration status? And I ask this question, I know this was a question that was asked more generally of all of you about the models when you took the survey, but I'm specifically asking the question with this model because as some of you know, with the Affordable Care Act, you have to be a citizen or documented resident, documented immigrant to be able to participate and purchase plans on the health benefit exchange, even if you're using your own funds. So my question for you is, should this be open to, sorry, I should add some more context here. There would need to be some kind of administrative modification that would allow undocumented residents to buy off exchange. Any feedback on that about including undocumented residents? Let's see, am I seeing any hands there? Yeah, Dr. Kovar. Oh, let me get you unmuted here.
Any
Sure.
way you slice it, people, everyone should be included. There's ethical, moral, financial, any way you put it. If you talk about undocumented people, they're so expensive when they show up late that we should try to have the actuarials cost out that piece, even if you only have a financial concern about this. And on the other end, the mean-spiritedness of making someone who's documented and here legally wait 5 years before they can even participate in a product is just insane. And there's just no reason for it. It's not like people are coming here because they're coming so that they could buy insurance after 6 months. But it just makes no sense. And it's hard to imagine that the legislature wouldn't want to do something with that.
So it sounds like you're in support of including that in this model, including undocumented residents in this model.
Absolutely.
Okay, Dawn. Let me unmute you
I
here.
need to unmute you.
Yeah. Are you doing it, Liz?
Yep.
Okay. Go ahead, Dawn.
The easy answer is what Dr. Kovar said is yes. And there's no way to get around it. And that's what makes this system, I think, unattractive. I hear too often people saying, I don't want to pay for other people's insurance that aren't citizens. And so you just have to say yes. And that's with all the plans. And that's universal. Either it's universal or it's not universal.
Okay, thank you, Dawn. So I hear an echo for that. Representative Macri?
Thank you. So yeah, I mean, I obviously agree with these guys. I would just say, it's interesting to frame it as sort of building off a cascade care. I think cascade care was trying to get at something different, right? I do believe cascade care is a big improvement over what the status quo was for the health benefit exchange plans. But that cascade care was trying to make an improvement in terms of access and standardization, driving towards affordability. It wasn't trying to do what the goal and intent of this work group is, which is to really create universal care models. So while cascade care, I think, is a really important step on the way, and this option C sort of imagines out how we might expand on that. We're not starting from the goal and working backwards. We're sort of looking at where we are and the steps we could take. And maybe we need to reconcile between this option C and either A and B to figure out what that kind of fuzzy middle space would be, because it will take time to do the transition. But as a standalone end goal option, I'm not seeing how that works. So it's already the undocumented coverage is a known shortcoming of the Cascade Care plan that, I think folks are intending to work to solve towards that problem.
Thank you for that. That actually is going to segue very nicely to a question that I'll be asking you about transition versus end state for this model. So thank you. I see Kelly's hand up.
Yes, am I on? Yeah.
You are on, yes.
Yeah. Two comments. One, I mean, if COVID has taught us nothing else, it's that, yeah, everybody's healthcare is your own healthcare, right? Your own safety, your own, and costs. We're going to pay for it one way or another. So it's just a no-brainer as far as I can tell. And then in terms of what Representative Macri was saying, I think that when I think the way I started imagining number 3 is kind of the current state that we're in plus a little more. Mm-hmm. And I know it's very important to me that we consider the costs of the current state and the current way of being. So I don't know, Representative Macri, if you could handle it from that angle of where are we now? Where will we be very shortly? And including that in the mix, not as our goal, but as our comparative numbers.
And I think that segues to a question I'll ask next, but before I do, I just want to make sure we heard from Sybil. I saw your hand up earlier. Did you have anything you wanted to say? Let me see if I can unmute you here. There you go.
Thank you. Yeah, I'm sorry, I got back a little late. I just wanted to be on the record saying we fully support coverage for undocumented folks and want to make sure that that is covered in whatever plan this group recommends.
And a point of clarification for everyone that I learned that I want to make sure I said, and I hope I'm not repeating myself here with this group. It's hard to know what I've said in the past meetings versus this one, but the actuarial models actually will, if we include undocumented residents in this model, we'll be able to actually see and compare both scenarios. So that I think will be probably useful information for all of you to have. Let me actually kind of build on what Representative Macri said and ask the question. I know some of you are not fans of this model at all and want to see it analyzed for the purpose of seeing basically how the current state of affairs looks and costs compares to other options. But recognizing that a fill the gaps model by its nature doesn't change the overall system and the many of the problems that we've articulated as a group and impacts only a segment of the population, do you see this as just a first incremental step toward one of the other two universal healthcare models that you've discussed today, or an end state in itself, or not an option at all? Any reaction there? Dr. Kovar, let me unmute you here. There we go.
Clear step backwards. It's another finger in the dike. It takes all the pressure off of reform and anything that's going to bring the cost of care down.
Okay, so you don't see it as a valuable transitional model. In fact, could do more damage than good. All right. Any different opinions on that? I saw some nodding heads there. I'm curious if there's any other opinions on that. Okay, so it sounds like, and the US culturally silences agreement. It sounds like all of our group generally agrees that it's not a model that you'd like to see in transition. Michelle, you wanna jump in here? Let me unmute you. There you go.
I guess I just want to think a little bit about what filling the gaps could mean. And, prior to our current state of uninsurance, back 3 or 4 months, most of the uninsured were our undocumented population. And so filling a gap where you can cover that population is still a really meaningful change in extending coverage to the entire population, coverage options. And I'm not saying it's a single payer option, but it is access to coverage that they don't have today. And so it is still, I think, one, in my humble opinion, a step to getting better access than we have today.
Does any of our work group members have a reaction to Michelle's thought there? Yeah, Dean, let me unmute you here. It's good. Third time's usually a charm. There we go.
So, yeah, I kind of agree with what Michelle said, but my real concern would be that once you take that step, it'll be, we did healthcare, and momentum would be lost. And so I think if there's a step, it's got to be a lot bigger of a step.
Okay. Yeah, I think that sounds like what Dr. Kovar was saying with finger in the dike there. So,
Jamie, and I just want to reiterate that the first group that we were with talked about this as well, the kind of back and forth. The comment that someone made, I thought that was quite astute, was that they'd be willing to entertain it as a transition step if it was packaged with something else that said, we do step one here, a legislative piece that would have all the pieces laid out, and that it was, came as a whole, but outline the steps.
okay, I'm going to move us on unless there's any other thoughts on this response. Sounds like generally some strong skepticism against you. Oh, Kelly, please, let me unmute you. Whoops. Go ahead.
I want to inject urgency this week. People can't afford what we have right now, and that's just not a big enough step. It's just not. I mean, yeah, it's not enough.
Thank you for that message. And that is also one I've heard quite a lot in the last few months. Okay, here's a question. Should this model include those with access to employer-sponsored insurance who are unable to afford their portion of the cost sharing? So currently, as many of you know, with the Affordable Care Act, if you have access to employer-sponsored insurance, you're not able to purchase options on the health benefit exchange. In this case, we would ask the model to consider adding folks where their cost sharing exceeds a certain affordability threshold and they can participate in this model. Any reaction to that? Yeah, Vicki. Let me see if I can unmute you.
Oh,
there we go.
Yeah, okay, thank you, sorry. I think, you know, in the Affordable Care Act, they wrote the language wrong, and so the families who, if the employees' cost sharing wasn't more than the 9%, then they couldn't access a QHP on the exchange. And so there were a lot of families that were left out of affordable coverage because of that loophole. This could help address that. So I think it would be important to be able to include the families got left out of affordable coverage because of that. That being said, I don't know that people consider QHPs affordable coverage all the time. So, but yes, I think it'd be important to include them because of that issue.
Sybil? Let's see if I can unmute you.
A family glitch.
Okay, okay, there we go.
There we go.
Yeah, I would agree. I think that as I was sharing with this group earlier, unions have fought for really strong health benefits for decades. At the same time, many employers are rolling back coverage and making it worse and worse. And so I think that people who are employed, many unfortunately really need a more affordable option. So I think it's really important for people to have the capacity to opt into this if they need it.
Thank you, Sybil. So it sounds like echoing that if folks would like to see these individuals included as eligible. Dawn, let's see if I can unmute you here. It's not clear to me why sometimes I can unmute and sometimes I can't.
No.
Am I the only one trying to unmute him? Everybody else stop and I'll try. Okay, I'm going to ask our tech person, New York Liz, can you take care of that? I'm going to take Representative Macri, and then I'd like to come back to Don so he can contribute. So New York Liz, can you see if you can get Don unmuted? Thank you. Okay, Representative Macri, hopefully we can get you unmuted here. There we go.
Yeah, so I think this is a model that builds off of our current structure, right? And we talked about this glitch, the family glitch in the federal access. But I want to comment, maybe echoing what Kelly said. I think the COVID crisis has really exposed the shortcomings of the current structure, and I think I'm queuing into these things that we're hearing now. So the family glitch has existed. So some people we know have not been able to get coverage because they can't afford their spouse's coverage at work, and they're not eligible to get plans on the exchange, even if they could afford plans on the exchange, which is a big question. And now we are faced with, I'm hearing from many employers who are saying, like, there's no place to go in our financial picture right now. So we're looking at reducing health benefits, increasing employee cost share on benefits. So it just, like, the whole thing is a house of cards to some extent. And one major crisis like the one we're going through now, where which exposes how healthcare is so tied to employment is a vulnerability. I say that also knowing that the legislature's ability to pass policy in this area is going to be difficult, right? So many of us have been working and talking about how we can do premium subsidies on the exchange, how that could be a next step in cascade care. Well, Medicaid enrollments, they've gone up 16% in the last 3 months, and the legislature is going to have to figure out how it's going to manage that new expense, which makes me very concerned about how we might be able to address the affordability issue for the kind of that next tier of folks kind of in that income right over above the Medicaid enrollee population. So I think there are these political tensions that are real that makes me think that we do have to, in some ways, think about incremental steps. But I think it's really important that we take the lessons from the crisis that we're in right now to really look at where those greatest vulnerabilities and gaps in the system are, and to try to address those along the way. And the family glitch, it was a known one, and that's exacerbated now by all these other challenges of large wave of unemployment and just pressures on existing businesses, financial pressures.
So it sounds like the tension I'm hearing that, and this gets back to the transition question, the tension I'm hearing that we're navigating here is the piece that Kelly illuminated that Representative Macri echoed, which is this crisis is illuminating in a very real way the problems with our system that some of us may not have really seen or understood before. And while there's an urgent need to address some of the catastrophe that's arisen with people losing their insurance or their coverage, and so that would be an argument for a transitional approach. There's also a real risk that if we use a transitional approach, we might call it good once the COVID-19 crisis is passed. And so that I think that's how I'm hearing this transition, this tension playing out in your comments. Okay, I think we've got Don unmuted. So Don, thanks for your patience.
Well, to answer the question whether or not to pick up what employers are unable or are willing to pick up, the whole idea of being in business is to make a profit. And once you get a certain amount of employers not picking up stuff and being able to have some of their expenses picked up by some other system, you're going to incentivize businesses to more and more to not pay for their business. And the other thing, being a business person, one of the things, once you set a pattern of expenses, you can afford it for a long time into the future. But if you take it out of your expense system, it's hard to get used to all of a sudden to incur that expense again. But the other thing is this is a perfect time to go for the biggest and best system where everything is in a disarray, and jump in and offer the best system possible. And one of the problems with just taking one step at a time, sometimes you never get to the second step, and then all of a sudden the first step disappears. So I would be really hesitant about thinking about this approach.
So Don, you raised a really important unintended consequence or potential unintended consequence that actually this is the first we've heard in the 3 discussions. So I think I appreciate you raising it, that if this model includes employees who can't afford the cost sharing for their employer sponsored coverage, that could incentivize some employers to pass more of their cost sharing along to the employee. They figure the employee's gonna get covered anyway. And I also heard an important echo of what I've heard from several of you, that transition's not going to get us there, and this is our chance to go for something really meaningful. We've got 2 minutes left, and I have one final question to ask you, which is, which, if any, elements of this model should be modified that haven't come up yet? Are there any other thoughts you want to put out on the table before all of our colleagues are beamed back into this room? Anything we missed here? Dawn, and oh no, you got muted again. Let's see if I can get you on. There we go. Yay. Go ahead, Dawn. No. Okay. Sometimes technology is not our friend.
Are you unmuting him or am I?
I am.
Okay.
Everybody else, hands off the trigger. Let's see if I can get him unmuted. Okay, for whatever reason, it's not working. Liz, you want to try? I don't know why I can't do it. Yeah. Okay, let's have, did you get it?
Let's see if it works.
New York, Liz, can you do it?
There he is.
Oh,
Okay,
yay, okay.
There's two Liz's on here too. That's also confusing.
Okay, Don, final words.
The thing that I want to really point out, and I'm getting so old now, I'm almost trying to lose my thought, but it's an important thought, and that is all systems, if you're going to go to universal health care, you have to take the profit motive out of the insurance company. In other words, it's going to just keep escalating higher and higher because companies can raise rates if they lose money, but when they make money, they don't just pass the benefit back to the consumer. And one of the flaws is that the system doesn't have a cost sharing. It has cost sharing, but it doesn't have profit sharing between companies built into the system. And so you're going to constantly face escalating costs.
Yes, and I think that goes back to 2 meetings ago with all of us together when we were talking about the problems with our system. Thank you, Don. It looks like all of our colleagues are coming back to our room here for our report out, and happy news is we're not too far behind schedule. We're only 4 minutes behind schedule. So as a reminder, I'm going to ask all of our work group members to keep your video cameras on, and that way you'll be at the top of my screen and I'll be able to see you and call on you. And I'll ask all of our members of the public to continue to keep your cameras off. We are struggling a little bit with the mute and unmute in here, but we'll do our best. We're on the home stretch here. New York, Liz, can you let me know when everyone's back in?
See if I got my thing.
Let's see. I see Nora.
Hi, I believe we're missing 2 people.
Okay.
Yes.
All right. Well, thank you everyone for your patience with the technology today. Appreciate it.
We have
everyone. Okay, everyone's back. Wonderful. All right. So now we're going to spend a few minutes. I'm going to ask the facilitators from each model to just do a quick recap of the key themes that they heard and outliers that they might have heard in their discussions. And we'll pause and just see if our work group members have anything to add. We are going to need to wrap this up promptly at 3:35 because we'll need to move it to our public comment. And we do have a number of people who want to comment today, so I do need to leave time for that. Let me start with Janine, who's going to give us a recap from the Universal Healthcare State Administered model. Janine, why don't you get us kicked off here?
Thanks, Jamie, and Shane, jump in if I miss anything. We spend a lot of our time talking about the need for a mandate in this type of model. And I'd say probably all 3 of the groups leaned more towards it being more a la Medicare, where you are eligible, and in some cases maybe at birth. Although there would maybe be a need for a mandate as you transitioned into this new model. But the challenges would be that you couldn't, it's hard to do in Washington State because they don't have an income tax, so you couldn't do it like the ACA has. There was some good discussion in all 3 groups around supplemental coverage and or substitutional coverage. Possibly allowing you to buy more enhanced benefits beyond this model. But There's always the challenges of having those who can afford to buy something else would maybe then want to pull themselves out. So the issue of opting in versus opting out would need to be further addressed, and to avoid that sort of healthier population of leaving the universal model. But a lot of these issues around this probably also needs to be aligned with how you would be financing, and so what's the relationship between who's paying, how it's being paid for versus how you get people to get engaged in it. When we talked about the federal programs or the 1.5, there's lots of challenges, as everyone recognizes, about these programs and being able to align them and pull them in. There was some discussion of some of those dollars may be necessary to really help fuel this and sustain this. But there was some discussion about moving maybe in a more transitionary way in order to be able to stand up something more immediately rather than waiting for years to get further waivers for Medicare, say, for instance. There was a lot of discussion about need for choice, though, all along the way, allowing it's just an important part. And as you think about transitions from their anyone's current benefits. And as far as benefits, I think there was sort of all three groups really discussed the need for adult vision and dental, and asking the actuaries to be able to sort of sub that out as to what those costs would be, to be able to really see that. We had some robust discussions about alternative providers and how that works with current Washington law about any willing provider. And so the concept of even more of a full, going along the way to even raise the old security trust bill and how they addressed it in terms of if you have back pain, then any provider that could provide. And then how would we model that? We had some discussions. And then long-term care seemed like all groups really felt it was very important, needs to be aligned with the new legislation that's coming out of up to be for your long-term care benefits, and how that would align, maybe could be folded in at some point or even immediately, but wanting to see those costs with and without in the new model. So
Thank you,
I think
Janine.
that summarizes.
Shane, do you have anything to add?
I think Janine did a great job summarizing brief points. Additionally, just as you put yourself. Thanks.
Shane, we can't hear you very well.
Yeah, because people are on mute. There was a lot of robust discussion about different benefits and whatnot, and I just want to point out that we're going to try and develop these models to be dynamic, and what that means is that just because we heard people had interest in it today, it doesn't mean it's baked into this whole enchilada that's going to have a giant price tag on it. We'll have the ability to look at, what the associated costs are for some of these different options, and if we need to peel them off as part of the final programmatic recommendation that goes into the report, we can do that. But I do think that the major exercise here was to see what types of things we should be considering so that we can do some of the financial modeling to help inform some of that discussion about, and which actually brings me to the next point, which was there was really good conversation and diverse opinions about political feasibility and financial sustainability. And a lot of those will honestly just be informed by the fiscal impact. So I just wanted to say thank you for all of the feedback. It was really great, and people really are thinking big picture, and there's going to be opportunity to pull different levers in the model as we get further down the road.
Excellent. Okay, before we move on to the Universal Healthcare Distributed Administration, did we miss anything with that recap, work group members? Does that pretty much cover it? Awesome. Okay, let's move on to Nora, who's going to give a recap for the distributed administration one.
Right. So we had some good conversations about this is for the distributed model. Obviously, the main difference from option A is that there are insurers involved, and the first thing we talked about actually impacts both option A and option B, which is the question of how much cost sharing, if any, should participants be expected to engage in, both from a premium standpoint as well as from deductibles and point of service cost sharing. And what we heard was mostly qualified yes, that there should be some cost sharing. There were some folks who said that there shouldn't be cost sharing because the impact on reducing care was just too negative, and also that because the program would be funded through taxes that ultimately were paid by Washingtonians, that they were already paying into the system. But a lot of folks talked about the potential benefits for having cost sharing, and a lot of the cost sharing really was about the utilization. So, you know, when you go to get care, what we heard was that it was really important not to set up a level of cost sharing or types of cost sharing that would keep people from getting needed care, particularly from coming in for preventative care, for dealing with chronic problems, et cetera. But that having care that incentivizes, or having cost sharing that incentivizes getting good care and also acts as a protection against low value care. Several people talked about the need to protect against using care that is either not beneficial or even potentially harmful, and that might be something that, you know, that providers were pushing, but people didn't really need, that it definitely had a role for that. So that was a big, across all three groups, we heard a lot. And then we talked about specifically around option B, we talked about the issue of the extent to which the state should be really setting the rules and using the insurers more in a administrative capacity versus giving the insurers more leeway to design their insurance products. And for the most part, what we heard is people had a real interest in insurers being in the role of third-party administrators. That they found that was a role that everyone kind of seemed to agree was beneficial for the insurers, but noting that when they're given more leeway, that it adds costs to the system, and that if we were looking for lower administrative costs, having them be given less leeway, potentially having fewer issuers that were engaged could be useful as well. Thinking about the number of, if you're implementing value-based programs, having a larger number of enrollees will help really push the ability of the entity to have benefit with that. So we also heard that we talked about whether there should be, sorry, I'm reading my own notes and I can't apparently read and talk at the same time. Yeah, so, and then the third subject area that we talked about was whether option B was seen by folks as an end unto itself, like would this be the end state, or was it really more of a transition to something else, i.e. would it be a transition to option A, full state program? And it was somewhat mixed. I think there were a number of people who saw option A as the ultimate goal of getting rid of the insurers, but a number of other folks said that keeping insurers as particularly as administrative function providers was useful and also kind of more achievable, particularly in the short term, but possibly overall one person suggested that if this were the mechanism that was passed, you could kind of have there be a trigger where we'll see how well this works. And if it doesn't work, we could move on to option A kind of thing. So that's kind of the overall recap. Jared, did you have any additional things that I've forgotten to include?
No, I think you covered all of them. So nothing else to add. Thanks.
Okay. I see Ronnie has his hand up. Ronnie, let me see if I can, we need to unmute you here. Oh.
What if we actually included in this analysis or this model of insurance companies, what if we actually use that American principle of competition and said, Washington State will choose one of these insurance companies? There was discussion in the presentation that we watched beforehand about competition among insurance companies, but the reality seems to be that it's worthwhile for them to charge more for a service that they're providing to patients because they actually will get a higher percentage. So actually saying, we'll choose one of you might actually put real competition between that expensive part of our healthcare system.
So Ronnie, I'm hearing the proposal on the table might be, instead of having multiple insurers providing the administration, that it would be competition for one, maybe through an RFP process. We definitely have to move on to the final recap so we can get to public comment, but Nora, do you have a response to that, or is that something we should table and get back to him on?
No, I think that's an interesting comment to add to the mix.
Okay. Vicki and Dr. Tritko, I'm going to ask, I don't have time to go into long feedback right now because I have to move on to the final group, but if you have something very quick to offer, I'm happy to take you. Sorry to be such a driver here. Okay, Vicki, you're okay? Oh, sorry.
I just can you hear me?
Mm-hmm.
Okay. I just quickly want to circle back to the idea of co-pays and cost sharing and make sure that we understand that we're doing that because there's actually evidence that if you have cost sharing, it somehow keeps people from using coverage when it's not needed. You know, within the Indian healthcare delivery system, our tribal members come to our clinic and they don't have cost sharing. And I don't see that as an issue, but I think it might be an idea that bakes in some kind of discrimination into a program. And so we need to be very careful to make sure if we're thinking that there's actually something that backs that up and it's just not something we're carrying through that's part of an institutional way of discriminating against poor people, basically.
So some evidence for the benefit of cost sharing. Okay, I'm going to turn over to Liz to see if she can do a speed round on recapping what we discussed on Model C.
And Nora, can you please capture Vicki's comment and your notes so that when I put this all together, we have it. I mean, I'm going to listen to the recording, but I just wanted to make sure you got that one. This is Model 3 or Option C, fill in the gaps. And we had a lot of common themes across our work groups. We first asked our group, what are your initial reactions? A lot of response that this won't cover everyone, it'll be too expensive, and ultimately it doesn't control costs. However, folks did point out that it was the simplest path forward, but there would be challenges around things like rates and making sure that everybody gets into the program. Again, politically the most feasible model, but it's not doing much to address costs and saving money overall. And there were some folks that were sad. They didn't want to actually evaluate this model because they felt like it was a failure. However, others felt that it needed to be modeled because it models the status quo and it's important to be able to compare. And then there were some comments that it would potentially exacerbate the existing situation that we have going on. So our next question, building off of that was would you consider this an incremental step or a transition? There were many folks that said yes, that they could see this as an incremental step forward and a transition to another one of the models. However, the caveat there was that if that was true, that there would need to be assurances that the next steps would be taken. The other comment that many folks felt was that by using option C and just filling in the gaps, they were concerned that this would take away the political impetus to get something momentous done, and that it would be a failure at the end. So there's a tension there between really wanting to go big and get it done versus what's feasible, and they didn't want it to just be a step to nowhere. We also asked a question about immigration status, particularly on this model, because it would require some administrative cost in terms of setting up like a shadow exchange and additional help with cost. Resoundingly, everyone said yes, they would like to see all immigrants covered because it's ultimately not a universal model if we don't do that. And many folks pointed out that if there's anything that we've learned from COVID, it's that we need to cover everyone and that it costs us more in the long run. Folks did say around covering immigrants, they would like to see the cost offsets around including immigrants, particularly around dish payments and uncompensated care, and perhaps even looking at what's happening with employment and things like that in the eastern part of the state right now because of COVID. And then finally, there was a statement and a comment recommendation made that we should include a racial equity evaluation as part of our recommendation. Finally, our last question was around specifically, do we want to allow people who currently have employer coverage, but it's considered unaffordable, should we allow them to participate in such a program to fill in the gaps? And comments said, yes, if we want to have a real impact, we have to do this, and especially if it sets a better standard for affordability in comparison to what the federal guidelines are right now. However, there were some concerns about if we do if we're trying to delink health and employment, that this can be really challenging. And also there were some comments around the affordability. We need to be clear about what affordability metric we're using. Is it an individual's perception, or is it, for example, what's in the federal law? So we needed to get clear on what is considered affordable. Looking through here to see if there's anything else. I think the general consensus on this model that I heard across all the groups is that they really don't see how it addressed costs, and that's very concerning to a lot of folks in our work groups. So that's it.
Okay, I'm going to take one comment question from Bevan, and then I'm going to do a quick wrap up and next steps. Bevan? See if I can we're getting you unmuted here. Who's unmuting Bevan? There we go. Yay.
I just wanted to chime in really quick and reiterate the comment that I made, which is that we're missing a model here, which is written into the budget proviso, which is to look at a multi-state solution.
Yes,
thank you
for pointing that out. And I did capture that in my notes. Thank you, Bevan.
Okay, I'm going to just do a very quick wrap up because we are out of time, but I'd say probably listening to the report outs from all three groups, possibly one of the biggest tensions that our work group is navigating right now that we might not have even fathomed back in February when we last saw each other, is this tension between shooting the moon and dealing with the immediate impacts of this crisis. And in fact, the crisis even prior to COVID-19. I've heard a lot of you wrestling today with the risks of using a transitional model when in this moment you're seeing that people may be finally getting more broadly how much disparity and how many problems are in our system. So I think that's a tension that we're going to be navigating as we move forward, but in a couple of months we'll have some really good analyses coming from Optimus, and your input today is going to go a long way, I think, to helping them get those analyses going and getting them in front of you as soon as possible. In terms of next steps, as I mentioned, we're going to be getting back together in August to do our assessment using our qualitative criteria primarily that we articulated in February. And you also will get a status update from Optimus on the actuarial analysis. And down the road, like I said, we're looking at what our options are for adding another meeting or maybe doing smaller group meetings, and we'll be getting back to you on that as well. Before we move into the public comment, I just want to give an orientation to and of course, you'll get a meeting summary from us for your review, as always. We're going to synthesize all the input that we heard from you today, and then the actuaries are going to use that to confirm the models that they're going to analyze. One last piece that I wanted to mention that I think is really important for all of us to remember and appreciate, and that we learned a lot about today, is Optimus is going to do what they can to make these models really dynamic so we can test out some different strategies and see what their impacts are. And now we're going to be moving into public comment. There's going to be some similarities to what you've seen before, but we're going to have to do some things a little bit differently since we're on the screen. I have a list of 7 people who pre-registered, and then 1 more person, time permitting, that I'll take if we're able to get there. I will need to strictly enforce, as always, the 2-minute comment period, so that we can try to get as many people as possible. There's going to be a timer on your screen to help you track. Folks are going to make a public commentary to help you track that 2 minutes. I'm going to read the names of people that are signed up for public comment in the order that we received them so that you know when you're going to be called and you can be prepared. When your name is called, Liz, our wonderful HMA events lead, will unmute your mic and turn on your video. I won't start the clock until you're fully on the screen, so don't worry. And you'll have 2 minutes to give your comment. When your 2 minutes are up, your mic will be muted again and your video will be turned off. If you have written comments that you can send to us, that will help us for our records. So please do send your written comments to the email box where you signed up to make public comment. And finally, if you did not sign up to make a public comment today, but you do have something you'd like to share about the proceedings, please do go to our website, to HCA's website. There will be, as always, a survey following posting of the video that you can complete, and there's some open-ended questions there where you can provide feedback. You can always send us an email. So we do want to hear from you. Commenting on this screen here is not the only way. And we do share those comments with our work group. We have really switched to getting it to our work group before their next meeting so that they can review those comments in advance. So they will see what you have to say. And now I'm just going to read the names I have on my list so you can be prepared. First, I'm going to take Chris Curry, followed by Dr. Bruce Davidson, followed by Gina Owens. Bruce Cutter will be number 4. Number 5 will be Dr. Michael Mulroy. 6 will be Nicole Gomez. 7 will be Joseph St. Aubin. And finally, time permitting, I will take David Loud. So give me one moment. I'm going to put the timer on the screen here. And I'm going to ask Liz from HMA to unmute and put the video on for Chris Curry. And please state your name first and then we'll get going. Okay, Chris, you ready to go?
Yes.
Okay, go for it.
My name is Chris Curry. I'm a retired RN from Spokane and member of Healthcare for All Washington, an author-active ebook called Medicare for Q&A that's available for free download at healthcareforallwa.org/resources. I have no doubt that option A, preferably without the variant, is by far the best option. Its only downside is the high number of displaced workers. Nationally, it's about 1.8 million workers if Medicare for All were to take effect, which no longer seems overly large compared to the 30 million displaced by COVID. Economist Gerald Friedman estimated that over 70% of Washington's displaced workers would find new jobs within 6 months because of the broad array of new job opportunities that the single payer plan will stimulate. So we must not defer what is best for the common good just because some people will need to find new jobs. Therefore, I strongly recommend choosing option A, and I hope that you will all take a look at my book. Thank you.
Thank you, Chris. Okay, so next up is Dr. Bruce Davidson. So go ahead and start speaking when you're ready.
What follows is my personal opinion, comments, then a question for Chair Sue Birch. I am 40 years a practicing pulmonary physician. The May 2020 letter from 4 workgroup members left me concerned, amplified by today's meeting, for example, your Plan 1.5, single payer that mixes the VA system and for-profit Medicaid and Medicare in the same breath. The state law requires about 15 different constituencies be involved in this, but having 35 is quite unwieldy. The company called Centene is number 41 in the Forbes 500, revenues of $100 billion. It pays your workgroup member, Beth Johnson, $770,000 a year in return for $770 million in taxpayer money for indigent state Medicaid patients. You think COVID shows weakness? Centene projects receiving an extra $4 billion from COVID. You have UW leaders transforming UW from an academic and training institution into competing for community patient revenue, not planning the best universal health care Washington can afford. You have a Dr. Dettering from Kaiser, whose CEO took $20 million a year, regional VPs taking over $2 million a year, and insurer restricting access to save money for the boss. Look, half of Washington two-family homes gross less than $5,500 a month. Please explain the reasoning. Connect the dots for me. How and why grossly conflicted adult professionals like these will elevate a plan to gain the greatest possible benefit from universal care rather than burying it. Thank you for this opportunity.
Okay, thank you. Next up is Gina Owens. And if you go ahead and start speaking when you're unmuted and your video's on, I can start the clock here.
Can you hear me?
Yes, thank you.
Yeah. Okay, thank you. My name is Gina Owens. I'm a member of Washington Community Action Network, and I have 2 points. One is I heard a speaker while on this meeting today that made reference to a racial lens being used in creating these models. And I really appreciated hearing that, and I just wanted to second that motion because I think it's really important and critical since Washington State, we have so many diverse groups, and we want to make sure everyone's included. My second point goes to something I have not seen yet, and that is the fact that personal stories are very critical simply because in creating these models, we're creating them for the people of the state. That means that everyone is going to be affected by the policies that are created by you all. And so I would like to see more in terms of you all reaching out to the public and hearing and also incorporating public stories into your data and your policies. Thank you.
Thank you, Gina. Next up is Bruce Cutter.
Hello there, can you hear me?
I can, yes, thank you.
Excellent. Appreciate this, thank you. I'm a physician, I'm an oncologist and hematologist in Spokane, and I'm speaking to you from a lot of firsthand experience with both the business and the clinical practice of medicine. First of all, I'd like to thank the committee, again, as you addressed the compelling moral, ethical, and economic imperatives around universal healthcare. what I'd like to address today is the elephant in the room, which is healthcare costs. These costs considerably inhibit our ability to reach our goals. Good data indicates that US costs are per capita are roughly twice other developed countries. All of the costs are high, although drugs and admin stand out. There's a category of costs that I am calling dysfunction costs, standardized dysfunction costs. These are large and growing, and they're due to our non-system of care. Other countries, in contrast, have a single system of healthcare, which contributes considerably to their cost advantage. In order to address our issues of affordability and access, we're going to have to wrestle this to the ground. We're going to have to deal both with what we pay for everything in healthcare, as well as these structural dysfunction costs inherent in our non-system of care. Therefore, my opinion, what I would urge the committee is to move to a single system of care. There are different ways to do that, and that's much of the discussion for today and in coming months, but we must get there in order to realize our goals. So that's my 2 cents for today. I appreciate the time and have a good evening.
Thank you. Okay, next up is Dr. Michael Mulroy.
Can get this button. Okay, hear me and see me. Good. Good afternoon. My name is Michael Mulroy, a retired physician in Bellevue here. I appreciate the opportunity to participate in the group today and to make a few comments. And I certainly appreciate the work that the team has done impressively over the last several months. Several of my comments that I had prepared have been resolved by the discussions already that took place today, and I appreciate that. I'm left with 2 other queries that I want to leave on the table. Janine talked about the universal mandate as part of option 1, option A, and I did not sense a resolution there. And my comment from years of watching this is if you have an insurance pool where there is not a mandate to include all participants, then the healthy low-risk patients do not sign up, and you're left with a pool that is much more expensive to manage. I hope the actuarials, I don't know if there's any way that they can take into account the options of having everyone in or options for people to drop out, because it will cost more if there is an option to drop out or not participate. And I hope we can come up with a mandate. My second comment is about the last discussion about employer contributions to the payments. And Representative Macri talked about some of the vulnerabilities of an employer-based insurance system, but it works very well in the European systems. And I hope that we can consider that one of the options by regulating and demanding a minimum coverage from employers in Washington state. This state is so tax averse that changing to a system that depends upon taxation is going to be politically not, feasible. And I hope the actuarials again can calculate where we are both with employer contributions and without. Thank you very much for your time.
Thank you. Okay, next up is Nicole Gomez.
Hi, everyone. I'm Nicole Gomez, co-founder of Alliance for Healthy Washington, and I'm commenting today after reviewing the 3 straw approaches to universal health care. Most of my issues were addressed during today's comments, which was great to see. And I just wanted to make 2 additional points and also wanted to let you know that I agree with what Dr. Mulroy said, and I concur with his comments on the mandate. The 2 issues that I was concerned about was that we are looking at a cascade care approach or cascade care-like approach, and I just want to be make sure that we're aware that we're not doing any or duplicating any efforts. And then the ABC approach fails to include the component of cost control that is actually that this group was tasked with in the actual bill or budget proviso itself, the options to expand or establish healthcare purchasing in collaboration with neighboring states. So as long as we have a focus on that as well, I think that's it. Thank you. And thank you.
Sorry, Nicole, I think you got muted before you finished that last point. Can you just want to say?
Oh, I just wanted to say thank you to the committee and everybody for doing this work.
Thank you. Okay, next up is Joseph St. Aubin. And while we're waiting to get Joseph unmuted, I wanted to mention that I got notes from two folks who said that they had signed up to comment. So I think we have time to take them as well. And that is Tanya Atkinson and Michael, forgive me if I pronounce your last name incorrectly, Benefiel. They will go after David Loud. So please be prepared and I'll call your name shortly. Let me restart the timer here. And are we ready for Joseph St. Aubin? You can go ahead and start talking when you're ready. Are we ready to go?
Joseph?
Hi, Jamie. It appears that he is not unmuting himself. I'm giving him access to unmute.
Okay, why don't we move on to the next person and we'll come back to Joseph. Maybe you can chat with him to work that out. So David Loud, why don't we have David Loud?
Thank you to the committee, to everybody working on this very important project. I am a member of Puget Sound Advocates for Retirement Action and co-chair of the Healthcare is a Human Right Washington campaign. And I want to weigh in for myself with supporting option A. I was surprised in the breakout group that I listened to that in addition to vision and hearing, that vision and dental, the hearing wasn't mentioned. That's a key benefit that needs to be included in the plan. I just want to say that COVID has really shown that without universal and affordable health care, we're not going to be able to overcome this public health crisis. We're not going to be able to overcome the next pandemic. And we can't, without overcoming the public health crisis, how are we going to really effectively reopen the economy? I just want to mention two things that are going to require federal legislation that I hope we will all get behind. Number one, to achieve this goal, we're going to need major federal support and I believe more state control over the federal healthcare dollars coming into our state and the option for multi-state plans. The second thing is we need the ability to get a federal ERISA waiver. And this point came up often about self-insured employers so that we can prevent self-insured employers from opting out of whatever universal system we come up with. And thank you very much.
Thank you. How are we doing with Joseph St. Aubin? Are we ready for Joseph St. Aubin?
Okay, hear me?
Yes, let me just reset my timer and then you can go ahead. Okay, ready to go.
All right, hello. My name is Joseph St. Aubin. I'm a physically disabled person that relies on caregiver services to be able to live independently. Currently, I reside in a 2-bedroom apartment with a live-in caregiver. I have Medicaid for funding for caregivers. The agencies that DSHS contracts with are woefully inadequate to meet the task of providing qualified personal caregivers that physically disabled people can rely on. The agencies that DSHS uses fail in 2 categories. One, guaranteed service. There is no guarantee from one of these agencies that a caregiver will show up for their shift. I've had a few instances where my sister had to suddenly take off from her job in order to rescue me because a caregiver never showed up to help me. Number 2, a lot of these caregivers have never been properly trained, not even have an NAC license. Consequently, these caregivers do not understand the type of personal care assistance a disabled person requires in order to be able to function. This leads to all types of horrible scenarios. For these reasons, the solution is to allow the disabled person to select the home health care agency of their choice, much like selecting one's own doctor. A competent home health care agency will guarantee that a caregiver will show up when needed, and that caregiver will have been properly vetted, making sure that the caregiver has an NAC license, understands the type of personal care assistance a disabled person requires in order to be able to live independently. The problem is that these agencies are usually for-profit agencies which charge a lot of money for their services. Yet these agencies can make the difference between a disabled person's ability to live independently or end up in a nursing home. Please consider providing funds to allow disabled persons that require home health care caregivers to access services
I'm
from.
going to need you to wrap up your comment now, sir.
Yeah, I'm on my last sentence here. Okay. Or profit home health care agencies so that disabled persons can finally have guaranteed personal care services. Thank you very much, Sharon.
Thank you. Okay, next up is Tanya Atkinson.
Hi. I want to thank everybody for your comments and the work that you've done. I'm really actually pleasantly surprised about the 3 options that we had. I didn't have access to finding the straw poll of the complete 3 proposals, and I'd like to get some information on how to do that. But with the options that we have in the A, B, and C, I think the A is definitely the best. I am a single payer health care proponent. I worked with Whole Washington, and that program of having a single payer really saves the state a lot more money than you would think. Many people think that single payer actually costs, but it doesn't as much as that. Reducing the cost of unneeded healthcare expenditures that are spent trying to just deny people coverage. The other thing is that with the option of not including Medicare or Medicaid and other state proposals, that would really affect my personal health care because I am married and I'm not sure how that would transpire because my health care expenditure is for like $65,000 a year is the drug that I take. And to get that with just one plan and not be able to use my partner's plan in conjunction, I'm not sure how that was going to work if I can't have actually be included in this proposal because I have Medicare.
Thank you. Okay, final commenter is Michael, and forgive me, Benefiel. You can go ahead and start speaking when you're ready and I'll start the clock.
Okay, I am Mike Benefiel, Democratic PCO from the 23rd Legislative District. Achieving universal health care by itself does not solve the problems we have with our inadequate healthcare system. Our goal should be to provide all Washington residents with affordable and comprehensive health care. Comprehensive means, of course, dental, vision, long-term, etc. We cannot afford comprehensive health care for all as long as the insurance industry is allowed to put their profits ahead of our health. Closing the gap falls far short of the goal of providing affordable and comprehensive health care for all. We should exclude cost sharing because it hurts low-income families the hardest and it adds expensive bureaucracy to the providers. If option 1A or 2A is adopted, then the state coverage should be available as secondary for those with the excluded federal plan coverages. If option B is to be a stepping stone, it must be written into the bill as a transition and not left for a future bill. I would appreciate the chance to
speak. Thank you very much.
Thank you. Okay, folks, we have hit the end of our public comment period and the end of our session today. Again, I want to thank all of our work group members for your time. I know this meeting took a lot of preparation on your part, and we really appreciate it. Your contributions were outstanding today. We also appreciate your patience with our initial tech challenges. I can assure you that we have learned a lot from today, and we'll only be better at this by our next meeting. But again, thank you so much for your time and for your continued commitment. And we will see you in August. You will be getting, of course, bombarded with emails from me in the meantime. But everyone, please be well, stay safe. I look forward to seeing you in August. And yes, a big round of applause for all of you.
Thank you.
Enjoy your evening.